the hypertension, today we are going to discuss about the hyperaldosteronism. Before discussion of the hyperaldosteronism, we are supposed to discuss about the renin-angiotensin-aldosterone system. At the juxtaglomerular apparatus of the kidney, the prorenin is converted into the renin, and this renin is responsible for the conversion of the angiotensinogen into angiotensin 1. By the action of the renin, this angiotensinogen in the liver is converted into angiotensin 1. Now this angiotensin 1 is converted into angiotensin 2. Where? At the lungs. At the lungs, the capillary endothelial cells basically convert this angiotensin 1 into angiotensin 2 by the action of the angiotensin converting enzyme. So after this angiotensin 2 basically goes to the adrenal cortex. Adrenal cortex is basically divided into three parts: zona glomerulosa, zona fasciculata, and zona reticularis. So at zona glomerulosa, basically this aldosterone formation occurs. So this angiotensin 2 is responsible for the formation of the aldosterone. Now this aldosterone is responsible for the regulation of the extracellular volume. So this is the renin-angiotensin-aldosterone system. Now what this does, and actually aldosterone is responsible for the extracellular volume and potassium regulation. What it does, it increases the activity of the mineralocorticoid receptors and increases the activity of the epithelial sodium channels. This is the main action by which this extracellular volume and the potassium regulation occurs. So aldosterone is responsible for the regulation of the extracellular volume and the potassium. Besides this, some other actions are also related to the aldosterone, which we are going to discuss later. So what happens? So when we talk about the hyperaldosteronism, or especially primary hyperaldosteronism, we are supposed to check what is the action of the renin, what is the quantity of the renin, what are the quantity of the aldosterone. So we are supposed to check all the things related to the hyperaldosteronism, especially in primary hyperaldosteronism. So when we talk about the hyperaldosteronism is basically divided into two types. Number one, primary hyperaldosteronism. Number two, secondary hyperaldosteronism. When we talk about the primary hyperaldosteronism basically is the renin independent disease, means there is no role of the renin. But when we talk about the secondary hyperaldosteronism is basically renin dependent, means renin is increased, and renin is responsible for all of the action of the mechanism. So first of all, we talk about the secondary hyperaldosteronism. When we talk about the secondary hyperaldosteronism, what happens? This is because of the so many causes. First of all, if we talk about the renal artery stenosis, and it may be because of the fibromuscular dysplasia, it may be because of the atherosclerosis. So in renal artery stenosis, what happens? The amount of the renin is increased, and this increased amount of the renin is responsible of the rest of the action which we discussed before. Now, if we talk about the other causes, if there is decreased effective arterial volume, suppose if there is decreased effective arterial volume, for example, in congestive heart failure, in nephrotic syndrome, there is decreased effective arterial volume, so renin will increase, and renin will be responsible for the rest of the mechanism which we discussed. Now the third is that if there is loss of the volume, if there is severe dehydration, if there is blood loss, then what happens? There is this is being sensed by the juxtaglomerular cells, and the renin is increased, and renin is responsible for the rest of the mechanism which we discussed before. So this is the secondary hyperaldosteronism which is responsible for the rest of the process. So when we talk about the secondary hyperaldosteronism, so secondary hyperaldosteronism is basically because of these causes which we call the because of the decreased effective arterial volume, maybe because of the blood loss, maybe because of the dehydration, maybe because of the renal artery stenosis, and some other causes. Now, if we talk about the primary hyperaldosteronism, so primary hyperaldosteronism is basically the renin independent disease, means there is no role of the renin. So when we talk about, then it may be because of the adrenal, it may be the aldosterone producing adenoma, it may be because of the adrenal hyperplasia, it may be the adrenal hyperplasia, and it may be some other rare causes like carcinoma, adrenal carcinoma. So when we talk about the aldosterone producing adenoma, this may be the unilateral and this may be the bilateral. In most of the conditions, basically aldosterone producing adenoma are usually are unilateral, and in rare conditions these are bilateral. But if we talk about the adrenal carcinoma are rare condition, because beside this some other rare conditions are also found which we call the familial hyperaldosteronism. Familial hyperaldosteronism type 1, type 2, type 3 are also responsible for this primary hyperaldosteronism. If we talk about some somatic mutations are also responsible for the aldosterone producing adenoma. So aldosterone producing adenoma may be unilateral and bilateral. Usually these are the unilateral, uncommonly these are the bilateral. So when we talk about the adrenal carcinoma, these are also the rare conditions and usually found for the responsible for the primary hyperaldosteronism. So how the patient present with the primary hyperaldosteronism? Suppose a patient comes with uncontrolled hypertension. If there are more than two hypertensive are going on, the patient presents with the uncontrolled hypertension. The patient presents with the resistant hypertension. It is difficult to control the hypertension. If there is less than 40 years of the age and the patient gets the cerebrovascular accident, then you may subject the primary hyperaldosteronism. And if particularly if these are associated with hyperkalemia, if these are associated with metabolic alkalosis, if these are associated with the hypernatremia, so we can suspect the hyperaldosteronism, primary hyperaldosteronism. So what happens? Basically, it is not necessary. It is not necessary. The patient may present with the hyperkalemia, may present with the hypernatremia, may present with the metabolic alkalosis. Still, the patient may have the primary hyperaldosteronism. Besides this, the patient may present with the increased cardiovascular morbidity and mortality. The patient may present with the MI, arrhythmia. The patient may present with the increased left ventricular mass. The patient may present with the left ventricular hypertrophy. What happens to the kidney? The GFR is increased in the kidney and there is increased albumin secretion. So these may be the presentation of the patient who are having the primary hyperaldosteronism. Basically, the patients who have difficult to control the hypertension, 30% of the patients usually are found with primary hyperaldosteronism. So now we come to the next point, how do we diagnose the primary hyperaldosteronism? To diagnose the primary hyperaldosteronism, we are supposed to do the aldosterone-renin ratio. Aldosterone to renin ratio we are supposed to do. Then how do we do? Basically, we divide the plasma aldosterone concentration to plasma renin activity. Basically, we divide the plasma aldosterone concentration to plasma renin activity. So we are supposed to calculate the aldosterone renin ratio by dividing the plasma aldosterone concentration to the plasma renin activity. If suppose it is more than 20, then it may be the primary hyperaldosteronism. So cutoff value of aldosterone renin ratio is the 20. If it is more than 30, then it may be the confirmatory. If it is more than 30, so it may be the confirmatory for the primary hyperaldosteronism. Now, how do we confirm this? So to confirm, we are supposed to do some sodium loading test. We can do the IV saline challenge test. We can do the some other test, but commonly we do the sodium challenge test. What we do? Actually, we give the increased amount of the sodium to the patients. We give the increased amount of the sodium to the patient for 3 consecutive days. So after giving the sodium 3 consecutive days, we are supposed to do the 24-hour urine sodium. If it is more than 200 mmol per day, if it is more than 200 mmol per day, then we are supposed to check the 24-hour urine aldosterone level. If it is more than 12 microgram, this is the confirmatory test for the hyperaldosteronism. So this is the test for the primary hyperaldosteronism. Now, what other tests can we do? We can do the CT. So adrenal CT. If we do the adrenal CT, we can find the aldosterone producing adenomas. We can find the adenomas. Adenomas may present with a less than 3 mm nodule. As a less than 3 mm nodule, there may be the adenoma of the adrenal gland. Besides this, if there is more than 4 cm mass in the adrenal gland, then you may suspect the adrenal carcinoma. So CT scan is the investigation by which we can detect the adenoma, we can detect the adrenal carcinoma. Besides this, we can do the adrenal vein sampling. Adrenal vein sampling is the invasive test, it is an expensive test. So usually it is not done on routine basis. But adrenal vein sampling we are supposed to do to distinguish between the unilateral adenoma or bilateral adenoma, or you can say the unilateral problem or bilateral problem. So we can do the adrenal vein sampling. So this is about the test which we can do in the primary hyperaldosteronism. Now, how we by the activity of the aldosterone renin ratio, by the plasma aldosterone concentration, and by the action of the plasma renin activity, we can detect whether it is the primary hyperaldosteronism or it is the secondary hyperaldosteronism. Now, how do we treat the disease? So for the treatment of the disease, there are two kinds of management. One is medical management and second is the surgical management. In medical management, we are supposed to give the mineralocorticoid receptor blockers. Mineralocorticoid receptor blockers like spironolactone and eplerenone we can give. Actually, we are supposed to choose the patient, whether the patient is suitable candidate for the surgery or not. For example, if there is bilateral adenoma, then patient is not candidate for the surgery, and the lesion is bilateral, the patient is not suitable for the surgery, then we are supposed to give the mineralocorticoid receptor blockers. If the patient having the disease unilateral, for example, aldosterone producing adenoma, usually most commonly are the unilateral, then the surgery is the choice for the management. And if we do the surgery, the hypertension is corrected, the hyperkalemia is corrected, and the metabolic alkalosis is corrected. So if the patient is not suitable for the surgical management, we are supposed to do the medical management by giving the mineralocorticoid receptor blocker. So this is the brief about the aldosteronism, or you can say the primary aldosteronism in the continuity of the chapter of the hypertension.